Thank you, John. And I appreciate the opportunity to speak. From the East Coast, from the West Coast, from Germany, our presentations were put together without necessarily coordinating, and I have some additional slides that I will skip through since we've covered some of this area quite well. But just to let the audience know, the Klaus Garbo reference in JCO is here if you would like to look into that in more detail. But let's get to a U.S. medical oncologist perspective on follow-up in stage 3. And I think in many respects our perspective is similar to that in Western Europe. But I've got some evidence that backs up these recommendations that I think is worth discussing. This is an important paper from the Memorial Sloan Kettering Group. And it's important to look at the background of what they did. They studied over a 10-year period all of their resected stage 3 patients. These are patients who had been rendered NED and then were followed in a very, I would say, stringent follow-up program of HMP, CT scan, and lab tests every 3 months for the first 2 years, then every 6 months for 5 years thereafter. And so out of this data set, they found 340 patients who relapsed. And then they broke down the sites of relapse, how the relapse was determined, and so forth. And I think this is very instructive in our developing a framework for recommendations for follow-up. As you can see in the lower right panel, this is depicted in bar graphs. Local in transit recurrences were about 1/3 of the recurrences, nodal 21%, systemic half. And of course, this will vary depending on the makeup of 3A, B, and C, but this was the Sloan Kettering experience. And it's not surprising that for the local in transit recurrences, the vast majority of recurrences were picked up by the patient or a family member, and a smaller part by physician, almost none by imaging. By contrast, in the systemic recurrences, it's understandable that the majority of these were detected by imaging. Now this panel, I think, is very helpful. The upper left panel just breaks down the relapse-free survival in the 340 patients who relapsed. So when you look at these curves, you'll say, all the curves go to 0. Well, that's based on the makeup of the population. But we can look at the tempo of recurrence. And it's not surprising that there's a slower tempo of recurrence in the 3A patients as compared to the 3C. But what about stages 3A, 3B, and 3C, and how they recurred either local in transit, lymph node, or distant recurrence? And here in the 3A patients, local in transit or nodal paralleled each other, and by 3 years of follow-up, the vast majority of these recurrences had already happened, had been detected. Systemic recurrences were more delayed, out to say 5 years or 6 years. By contrast, in stage 3B patients, there was a closer grouping of the different types of recurrence, and in stage 3C, we see very tight grouping and a shift in the curve to the left. And this will influence the recommendations that the National Comprehensive Cancer Network is making in terms of follow-up. Now, the authors' conclusions from this study, and this could be debated perhaps, that they found little use for physical exams beyond 3 years for stage 3A, 2 years for stage 3B, or 1 year for stage 3C. CT scans, also little use for CT scans beyond 3 years for stage 3A and B, or 2 years for stage 3C. And as Axel has already mentioned, there were only 4 cases out of the 340 detected recurrences where elevated LDH was the first sign of recurrence, so we're not recommending routine measurements of LDH, even in this high-risk group of patients. They did break down relapse in the CNS, and I thought this was interesting and somewhat intuitive, that 4% of the first relapses were in the brain in 3A patients, and was as high as 13% in those patients with stage 3C. So this raises the issue of whether or not routine CNS imaging should be recommended. I'm going to skip this one, sorry. So where does this take us in terms of the U.S. perspective on surveillance? The American Academy of Dermatology, in their latest publication of guidelines, I think we're reflecting the fact that there are limited prospective data, and they acknowledge that. They do emphasize, as Dr. Weinstock did earlier, that at least annual H&P is indicated, especially with attention to skin and lymph nodes, and particularly with respect to educating the patient regarding self-exam. This is where the money is in terms of bang for the buck in detecting recurrence. Surveillance lab tests and imaging not indicated in asymptomatic patients, in their opinion, due to the low yield and the concerns for false positives. But fortunately, they did acknowledge that in certain cases of higher risk, that is greater than stage 2B, that imaging may be considered. Now, the National Comprehensive Cancer Network has come up with their own guidelines, and I will say that hammering out these guidelines has created more verbiage and more discussion in our committee than just about any other topic, partly because there is a lack of data. But we also agree that at least an annual skin exam for life is indicated as follow-up for patients with a diagnosis of melanoma. Routine blood tests not recommended. Radiologic imaging, of course, indicated to work up specific signs or symptoms. And as our first nod to the lead from Europe, we are now mentioning in the guidelines regional lymph node ultrasound. Now, in the U.S. perspective is that this is mostly of value in patients with an equivocal lymph node physical exam, or in patients who were offered to undergo sentinel lymph node biopsy but declined, or who had a positive sentinel lymph node biopsy and then did not go on to a complete lymph node dissection. But of course, we make the point that the nodal basin ultrasound is not a substitute for sentinel lymph node biopsy. In the U.S., the ultrasonography department is in radiology. It's separate from the clinic, and this creates a distance that I think reduces the utilization of this technology. But I think this is being viewed more favorably in the U.S. now. And of course, we also have to mention that any schedule guideline recommendation has to take into consideration other factors, genetic factors, newer emerging immunologic factors that are being developed, as the earlier speakers mentioned. So here's my final slide. This is the follow-up recommendation. That is, we recommend these common follow-up recommendations for all stages of patients, the ones I just mentioned. And then for stages 1A through 2A, the main point of this is that routine radiologic imaging is not recommended. This is the largest population of the patients in stages 1 and 2. And I think that this is an important contribution to the field because we still see patients coming in to our clinic who've been referred in by a well-meaning physician. They've just had a patient with a 1.2 millimeter non-ulcerated melanoma, and so they get a PET CT scan just before they send the patient to our melanoma clinic to make sure. Well, that's probably not indicated. That may be a misuse of our dollars. On the other hand, in the higher risk patients, those who have a pretest probability of harboring occult disease, that is stages 2B and 4, intensive follow-up with patient education is recommended. And we have to, for various political reasons, sort of hedge our recommendations by saying consider chest X-ray, CT, or PET CT scan. Now, in the earlier iterations, the frequency of this imaging was even more intense. The trend has been to change the frequency to less frequent imaging. Nonetheless, it's still, we are recommending a range of every 4 to 12 months for the first 2 years. Consider brain MRI. This is put in here annually, and this creates a lot of discussion. Annually for how long? Well, in the earlier study by Romano that I showed you, most of the recurrences in the brain occurred early. They were mostly in the stage 3C patients. A third of the CNS presentations were because of a seizure. Didn't need an MRI for that. So I think this should be read by the audience as consider brain MRI annually for 1 to 2 years in appropriately high-risk patients. And then again, routine radiologic imaging to screen for asymptomatic patients beyond 5 years not recommended. So that's the end of my presentation, and we'd be happy to, as a group, answer questions.